So when starting an exam, we're gonna make sure that our patient is, their posture is really good, right? We're gonna make sure that their gait when they walk in is normal, and we're gonna make sure that each part of the body, so is, not even, is pretty much the same size. We don't want one leg to be bigger than the other. We don't want it to be asymmetric. We're gonna check if the patient is in distress and if the patient can answer you with answers that make sense, so they're alert. Then we're gonna start off the exam by taking the patient's respiration and pulse. So back up just a little bit. We take the patient's pulse and respirations together, just so that the patient won't accidentally change their breathing rate. So we're gonna time it, right? So the way we would do this is by putting your 2 fingers on the radial pulse and then putting your arm on her lateral side of the shoulder. The reason why we do this is because we're gonna look at the rise and fall of her chest for her respirations, and we're gonna feel her heartbeat at her radial pulse. So what we're looking for is a normal heartbeat of about 60 per minute, and we're looking for a normal respiration rate at about 12 to 20 per minute, okay? So any abnormalities that we might find are gonna be that her heart rate is too fast, so that would be tachycardia, and then her heart rate is too slow, that would be bradycardia, and then arrhythmia is gonna be that her heart rate is gonna be like abnormal, so she might feel like she's skipping a beat or things like that, and that could lead to heart problems. We don't want her to be beating too fast, and we don't want her to be beating too slow. And then we're gonna, for the respirations, if she's breathing too fast, that would be tachyapnea, and then if she's breathing too slow, that would be bradyapnea. So we don't want her to be breathing too fast because that could lead to like infections of the lungs or even cause like heart failure. So we want her to be right in those parameters that I just said. Let's get the stopwatch. So she can have her eyes open on this particular test, but normally we would want her to be comfortable and just kind of resting, right? Also, we're gonna look for, when we're looking at the respirations, we wanna see if she's in distress when she's breathing or if it's like very strenuous to her to breathe. And then for the pulse, we wanna know if she has a fast pulse or like a weak or anything like really strong pulse, right? Because she shouldn't really have a fast pulse unless she just came from exercising, something like that. So sometimes it's normal for people to have a faster pulse than others, but we want it to be at a normal range. So let's start. We're gonna do it for 30 seconds, and then we're gonna times it by 2 to get the minute. All right, perfect. So for the respirations, we got 8 times 2, which is 16, so that's pretty good. It's within the parameters, so there's nothing wrong with that. Now we're gonna take the pulse. So right here, now you can take your hand off of her shoulder. We just wanted to see if our hand was moving, back and forth. But let's get her pulse. Once I get her pulse, we'll start. Perfect. So what we did there is we timed her for 15 seconds, and then we counted the pulse. We got 16, so you want to multiply that by 4. What is 16 times 4? The reason why you want to do that is because you want to get the minute per minute, the beats per minute, right? So 16 times 4, we got 64, and we said that our normal was going to be 60. So that's perfect. 64 is perfect for her respiration and her pulse. So the next thing we want to examine is her blood pressure. Blood pressure is systolic over dystolic, right? So systolic is going to be related to the heart's contraction of the ventricles, right? So when all the blood is in the arteries, right? And then dystolic is going to be related to when the ventricles have emptied, right? So the relaxation of the ventricles. So that's the bottom number, systolic over dystolic. The systolic number should be higher than the dystolic number. So what we're looking for is a blood pressure of anything at least a little bit under 120 over 80, which is the normal. Once you get up to 120 over 80, you're going into the prehypertension, and those parameters are going to be 120 to 139 over 80 to 89. That's prehypertension. A lot of people have that. And then once you go over that, it's going to be even more abnormal. So 140 to 159, and then over 90 to 99. That's going to be already the first stage of hypertension. We don't want that. And then 160 over 110 is going to be already the second stage, right, of hypertension. Over that, 180 to 110, that is going to be like really abnormal, and that's a crisis already. So 180 over 110 is you need to take some action because you might have a heart attack or a heart failure or anything. We don't want there to be too much blood in the arteries and then little space for them to go through, because we don't want those arteries to burst. If there's too much like plaque inside the arteries, there won't be a good flow. We won't get any blood towards all the organs and tissues of the body, you know? So that's kind of the normal parameters, and then the abnormal parameters that we're talking about. In order to take blood pressure, you want to make sure that you have the right cuff size for the person you are assessing, because if you have too big of a person and a small cuff, you might get a higher blood pressure, and you don't want that. But you're going to take the sphygmometer, which is what we're measuring with, right? And then you're going to wrap it around the person's arm. She needs to be kind of relaxed, right? Hold on, let me see. So basically, we're going to look for the brachial pulse, right? So turn your arm a little bit. 80% of the time, it's going to be medial to the bicep tendon, right? So if you can't find it, you want to ask the patient to extend their arm, and you will be able to find it. 20%, so it's right here. 20% of the time, it's going to be on the lateral side of the bicep tendon, right? So she can put her arm slightly flexed again because I found it. We want that artery to be in line with this little arrow. We're gonna put it on her bicep, so at least 2 centimeters above where I just marked, right? Because we wanna be able to put the stethoscope there. So we're having that face the artery, and we're gonna snug it on there just a little bit, right? We want it to be within the parameters, right, of the other arrows. So that's perfect. We're gonna have her rest her arm just on her right here, because usually we would have her rested on like a table or something. We just want to be able to read the sphygmometer. So what we want to avoid is kind of, we want her sitting up. Don't cross your legs, please. Face this way. So what we want to avoid is osculatory gap, the gap, right? So that's when you can't hear the pulse, but it's due to the systolic being higher, so her blood pressure being higher. So the way we're gonna get rid of that or avoid that is we're gonna okay, I can't talk with this on. So we're gonna pump up the cuff until we can't hear her pulse anymore. Then we're gonna take the air out. We're gonna read the sphygmometer, right? And then whatever the number is, the next time we pump up the cuff, we're gonna pump it up 20 more millimeters than of mercury than it was already. Okay, so that's how we're gonna know how high to pump up our cuff to each patient. All right, so the way that we heard it was we put the stethoscope on the brachial artery, and then we got about 160. So we're gonna pump it up to 180 when we take her blood pressure. Remember, we're trying to find systolic over diastolic about 120 over 80. So hopefully she's within those parameters. We don't want her to have hypertension, and basically, when I take her blood pressure and when I pump up the cuff, I'm gonna undo the cuff and deflate it about 2 to 3 millimeters per second, and then I'm looking for the first pulse, which is gonna be the systolic number, and the last pulse, that I hear, which is gonna be the diastolic number. Perfect. So that was just about 118 over 62, which is perfect. You don't have to be exactly in the parameters as long as you're not over 120. And even if you're a little bit over 120, you're still good as long as you don't get into that hypertension, which I told you was gonna be like in the 140s or 130s. You don't want to get up to there. And then as long as you're underneath 80 for the diastolic, you don't want to be too low, so you don't want to start getting into the 50s. You want to be in the 60s or the 70s actually would be better, but her blood pressure is pretty good. All right, so the next thing we're gonna check is her lymph nodes. So her lymph nodes, they're basically all over the body. Lymph nodes are all over the body. They're part of the lymphatic system, and they drain out anything that's bad. So they drain out fluid, swelling, and sickness, basically. So in a normal person, you won't see any deformities. In a healthy person, even someone who may be a little bit sick, sometimes you won't see any deformities, and it wouldn't be palpable because the lymph nodes are working, right? They're draining out everything. But in a person that's sick or has been sick, you may see some abnormalities, right? So you may see something that looks enlarged, right? That would indicate that her lymph nodes are probably infected. So you would see enlargement. When you palpate, you would feel something firm. You would feel something like very tender, and you would feel like kind of warmness on the skin, you know? And you would be able to probably see it if it was poking out on one side, especially if it's asymmetric. So this side would be bigger than the other side. You would be able to see that. There's different places in the system that you could palpate for lymph nodes, and they drain different things in the body. So for example, the front part of her neck right here is going to be the anterior cervical. You have some lymph nodes there. Basically, this is going to be superficial or deep to the sternocleidomastoid mastoid muscle, which is the muscle that kind of moves your head. So when you move your head this way, it pops out. When you move your head that way, the muscle pops out. So superficial or deep means it's on top or on the bottom of that muscle, and it's going to be basically from her jaw to her clavicle. So not too bad, not like right here, but not too frontward. So we're going to palpate right along that line till we reach her clavicle, right? Then she also has her posterior cervical, so that's the back of her neck. Basically, that's going to run across the same muscle that I just talked about, and it's going to be in front of her traps. So like right around here, not too far back, but not too far up, right? And then we're going to palpate also, she has a submandibular, right? So that's going to be right across here. And then, put your head straight. And then she has the, sorry, I made a mistake. The tonsillars, which are going to be right about here. And then the submandibular would be right under the jaw. And we have it on both sides. And then we have the submantle, which is going to be right under the chin, right? And then we have the supraclavicular, which are going to be right above her clavicle, okay? And then we also have the preocular ones right in front of her ear. So when we are palpating, we want to use all 4 fingertips, right? So we're using all 4 of the fingertips. We're applying gentle pressure because if they're inflamed, you don't want to irritate them even more. So basically, we're just going to be doing this. You want to make sure that your patient knows what you're doing because they might think you're weird. So you can stand in back of the patient, or you can stand in front of the patient and just palpate all of the areas, okay? So basically, let me remind you of what we're looking for and the abnormalities. We're looking for tenderness. We're looking for a firm spot. We're looking for enlarged lymph nodes, which I don't see anything from eye that's super large on her. So, and then we're looking for skin temperature, if it's abnormally like really warm, which would indicate that she has an infection. Sometimes it indicates cancer and a specific area in the body, because if you have an enlarged lymph node, that would mean that you aren't really draining all that bad waste and debris out. And you could just simply be sick because you have a cold or something, but it could also mean that you have cancer. So for example, the anterior cervical adenopathy. Adenopathy means enlargement of lymph nodes, right? That can mean that you have cancer in the orothorax, right? In your throat, maybe. And then just adenopathy with anything, lymphadenopathitis means that you have basically an enlargement in the lymph nodes and also inflammation, you know? Okay, so we're just gonna palpate it and let's see what her lymph nodes are. So just a gentle pressure. Okay. And then we're gonna come up here. And right underneath her chin. All right, we can check in front of her clavicles just because we know that there's lymph nodes right there, right? And we can check right near her ears. And then the last one would be right behind her neck, right? So we just want to check all of them. And she's very normal. She doesn't have anything that's too hard to where you could see, or she doesn't have anything that's like very firm and tender that's hurting her. A lot of the times, like, you would think like normal, you wouldn't see anything, you wouldn't feel anything, but actually sometimes a normal patient who is healthy again will still have an enlargement, right, of the lymph nodes, because maybe they were sick in the past and now when they're getting their check again, they still have that enlargement kind of. It just won't be tender. It will have a rubbery consistency, so sometimes you can populate those little spots. So now we're going to check her ears. For the ears, we're just going to check the outside. So I'm going to move this just a little bit. The outside of the ear. The outside of the ear is basically the lobe. You want to check the lobe. You want to check the helix, the antihelix, and the tarsus, right? So you're checking that to see if there's any swelling, if there's any pain, because swelling and pain would indicate that she has an external canal infection. So when you're looking at the external canal, if it's red on the walls, then you might have an infection. If it's swelling, then you might have an infection, because usually in a normal patient, there's a lot of there's a lot of room to look through. So you just want to make sure that the external canal doesn't have an infection. You will know if she has pain in her tarsus or if she has pain in her lobe that she might have an infection. So then we're going to check the medial or the middle part of the ear. We're going to go a little bit deeper, going towards the nose of her, and we're going to check the tympanic membrane, which is her eardrum. The eardrum should be a grayish, transparent kind of color. If it's not, if it's abnormal, then it will be like red, and that would indicate that she has an infection. You will be able to see a line on the tympanic membrane, which indicates that there's fluid building up behind her eardrum, and that would be an infection. It'll create like a little bulge. The tympanic membrane will bulge. If you have too much earwax in one ear, don't take it out, because it's not safe to take it out unless you know how to take it out. You would just go and check the other ear. And then basically that's what we're checking in the ear. We're also checking for hearing loss. So we'll use a different instrument to check for hearing loss and two different techniques to check for that. So right now, let's take the otoscope. All right, so we're just going to change the heads of this otoscope. Right, so we're going to put this one on. Make sure okay, we just want to make sure it has a light. So turn it on. We just change the heads, and then we're going to put one of these disposable things on there. All right. So now we have a light. So when we're checking the external canal, we're gonna hold the otoscope in the hand that we're checking the ear. So I'm checking her left ear, so I should be holding it in the left hand, right? And then I'm gonna take my other hand, kind of just pull up on her pinna on the top of her ear, right? So that we can see the canal straight, like it won't be curved or anything. We're gonna turn the light on. Hold on. Yep, the light. And then we're going to put it in her ear. with direct vision. We don't want to be looking in there already. With direct vision, pull her ear up a little bit, and we're going to look through the scope. We're going to go in very slowly, and we're going to go towards her nose. So her ears are kind of small, but the walls are not red, so we're pretty good with that. And then we kind of want to go in deeper so that we can see the tympanic membrane. And it is a very nice grayish, kind of clear color. So she doesn't have any infections. And then we can check the other ear. So you check it on both sides. So I switched hands because we were checking the other ear now, right? Okay, so a very nice color, same with this ear, not red or anything. Her ears are very small, so it's kind of hard to see the tympanic membrane. But yes, a nice color. Okay, so she doesn't have any infections in the ear. So if she did have infections, I told you that the tympanic membrane would say that she would have an infection in the middle ear, and that's called otitis media, right? So her tympanic membrane, her eardrum may be bulging out a little bit and maybe a different color other than grayish. And then for her external ear, there will probably be pain on the outside of her ears, so the lobe and the targus, and her external canal would probably be swollen, and there wouldn't be much room to move around, and the walls would be red instead of like whitish grayish color. So, and that's called otitis externa, basically. We did forget to take her temperature. You normally take the temperature right after you take the blood pressure. You don't have to take the temperature. That's why I forgot to. But basically, you would take the temperature if she was sick and you were trying to figure out if she had a fever. In the clinical setting, oral temperature is the gold standard, right? So the only time you would take anything other than an oral temperature if the person was having a heat illness condition. So regular or normal oral temperature is going to be 98.6 degrees Fahrenheit. So that's going to be about 37 degrees Celsius. You can get to 98 degrees, 0.6 Fahrenheit is normal. You can get to 96.4 degrees Fahrenheit, or you can go up to 99.1 degrees Fahrenheit. So that's about 35.8 degrees Celsius and 37.3 degrees Celsius. You don't want to go past those parameters, because if you go below that, you will hit hypothermia and you will need to rewarm the body. So under 95 degrees Fahrenheit. If you go above that, you will have a fever. So over 99 degrees, getting up to the 100 degrees is going to be a fever. An extreme fever will be up to 103 degrees. You don't want to get that high. You want to rewarm the body. If you are in an exercise setting condition, and you get over 105 degrees, you have hypothermia and you are basically about to die. So not really about to die, but if you stay at over 105 degrees, you will die. So basically what's happening at that state is you're having a heat stroke, your cells are starting to melt and die because your core body temperature is too hot. So at this point, you wouldn't take oral temperature, you would take rectal thermometer temperature. So yeah, she's saying no because she's like, you're not taking my rectal. So good thing she might just have a fever. So that's why we're gonna take oral temperature. Basically, this little thermometer, you just put right underneath your tongue and you hold it there. You don't want to bite on it, but we're going to put a little slip on it so we know that we don't contaminate. I'm just going to put it in the little slip, even though we know that it's pretty much clean because I cleaned it. Let's try it both ways. So we're just gonna turn it on, and then we're gonna put it right underneath your tongue, and we're gonna close your mouth and hold it there until it takes the temperature. Perfect. So it beeps when, okay, open. It beeps when it's done. And hers is 36.8, so we did say that it can be, there's no trash there. This is not my house. Okay, so we did say that it could be 36.8 degrees Celsius. That is within the normal parameters, so she's good on the temperature. And we didn't do it directly in her mouth, so we could just put that back in there. Wash it later, just to make sure. We don't want to be spreading diseases. Okay, so so far we checked her temperature, we checked her ears, like just the internal part of the ears, we checked her lymph nodes, we checked her blood pressure, and her respirations and pulse. So now we're gonna go back to the ears, just because I did it a little bit out of order, but it's okay. We're gonna check her hearing. So the way we check her hearing is with this tuning fork. Usually we want a 512 hertz tuning fork, something that will make noise, right? And you just pretty much hit it on, you have to keep on hitting it on a surface so that it will make a noise. But sometimes it's kind of hard with these. Sometimes they just vibrate. You want the noise. So basically what we're looking for is her conductive hearing, if she has conductive hearing loss or sensory neural hearing loss. Conductive hearing loss is just the first layer of hearing. So that's going to be from the external world to her 8th cranial nerve. And then sensory neural hearing loss is her deeper hearing. So that's going to be from the 8th cranial nerve to her brain. Okay? And we test this with 2 different techniques. We use the Weber test. That's where you just hit it. Once you hear it, you put it in the back of her head, right? And you put it equal distance from each ear, and you ask the patient if they can hear equally in each ear, okay? So if, say the person has blockage in one ear because of too much earwax, that would be an abnormality. You would hear conductive hearing in that ear, but your sensory neural hearing would go down. Why? Because that's the deeper hearing, right? You have too much wax in that ear, on the outside of it, on the not on the deeper layer of it, right? So that's the Weber's test, and then the Rhines test will be you putting the same thing, so hitting it on your hand, making that sound, putting it right on the mastoid bone, which is going to be inferior and posterior to the ear. So right about here, you're going to put it on there, ask the patient to let you know when they stop hearing the tuning fork, and then you're going to move it right in front of her external canal and see if the patient still hears it. That indicates that if the person can hear it, that indicates that air conduction is better than bone conduction, which in normal ear, that is true. But if she had an abnormality, say she had like an ear infection in the middle ear, so she had otitis medius, then that wouldn't be true. Bone conduction will be better than air conduction at that point. And you may not be, you'll have hearing loss. And then in that specific ear. And then it wouldn't be the same for sensory neural hearing because that is the deeper hearing. So you might feel like both air conduction and bone conduction are being affected at that point. So let's do the test. Let me just, okay. Here. Can you hear it equally on both sides? Or can you? Perfect. All right. So that her hearing is good on both sides, right? And then the other test would be hitting it again, going on the mastoid bone. Tell me when you can. All right. Can you hear it still? No? Okay, so we'll try it again because she should be able to hear it in each ear once you get towards the external canal, because air conduction should be higher than bone conduction. So if you put it right here, like once you can't hear it here, you should be able to hear it here, because we're trying to see if air conduction is better than the bone conduction when you put it right on the mastoid bone. And then again, I said that in a normal ear, air conduction is better than bone conduction. Okay, so let's try it one more time. Hold on. It's because these things don't get loud enough sometimes. I can't even hear it. Let's see. Ouch. I can't hear anything. Well, that might have been our first and only test. Because I can't hear anything. Okay. There's only this sound. Alright, maybe we'll come back to that. Okay, so now we're done checking her ears. We're going to check her nose. It's okay to use the same otoscope and the little disposable thing that you use with her ears for her nose. So for her nose, we want to check if she can breathe out of both nostrils. So the way we're going to do that is we're going to ask her to plug one of her nostrils and inhale. Can you breathe out of that one? Perfect. Okay, and then we're going to ask you to plug the other nostril and do the same thing. Okay, so she can breathe out of both of them. Then we want to check if she can smell, right? So the way we're going to check that if she can smell, we're going to take something that has like a strong aroma. We're going to ask her to close her eyes, and then we're going to ask her to plug one of her nostrils, and then we're going to put the aroma kind of close to her nose and ask her if she can smell it. All right, so let's do the other nostril. All right, can you smell it? All right, so perfect. So that's just an easy test to see if she doesn't have like a deficit in her smelling. So anemosia, right? If she has a lack of smelling. And then the other things we want to check with her nose is, one, we want to check her discharge. So if her discharge is a clear color, then we would know that she probably has allergies. If she was sneezing a lot, she'd probably just have allergies. But if her discharge was a different color, so if it was like yellow, then she probably has an infection. She's probably sick. She probably has nasal congestion, everything like that. So we also want to check the mucosa, which is like the membrane, probably like, the outside or inside the nose, but like the membrane of the nose. We want that to be a normal color. We do not want it to be super red. If it's super red, that would indicate that she has an infection. And then we want to check the tubercles, which are going to be on the lateral side of the nose. It's like a shelf-like projection. If those are too big, if those are going to be too big, like polypoid growth, that would indicate that she has either allergies or like an obstruction symptoms. So we don't want those to be that big. We also want to make sure that her septum is not deviated, because if her septum is deviated, then she's probably going to have trouble breathing, so out of a certain nostril. So just by looking at it, her septum does not look deviated. But let's look at the inside. We're going to use the otoscope. We're going to tilt her head backwards just a little bit, and then a little bit more. And then we're going to hold the tip of the nose back, okay? So I'm going to move this chair. Turn the otoscope on with the light. You could use the same one, just put it right up in there. Put it in before you start looking into the nose. Okay. So okay, so in that one nose and that one nostril, she does have a little reddish, just like very little reddish around her, you know, the mucosa. Maybe she might have a little bit of thickness, maybe. But actually her discharge, basically her snot, is clear. So she could be still fine because it's still clear. Her tubercles are right there. There's a lot of room. Okay, she's gonna have to call me back later. There's a lot of room in there to see everything, so let's check the other nose. Wow, there's so much room in this one. Okay, so same thing. I'm gonna put that up now because your snot is on it. Okay. Okay. So we checked her nose. We checked her nose, the smell. We checked if she could breathe through both noses fine, both ways, and we checked like the inside of her nose. It's just a little bit, just a hint red, but her discharge is fine. And the tubercles are fine. So now we're gonna check her sinuses. Her sinuses have a lot to do with the nose because the maxillary sinus basically drains everything to the nose, right? So you would check the mucosa or the discharge first, and we did check the discharge, it was clear. So to check the rest of it, you would palpate kind of to see if there's any pain, especially on the maxillary teeth. So she has the maxillary sinus, which is going to be right below her eyes and between her nose, right here, right? And then she has the frontal sinus right above her eyebrows. So you're just going to palpate with those four fingers again, right? And you're kind of just checking if there's any pain. So you're not going to palpate really hard in case they do have pain. You're just going to ask them, so is there any pain? You're just going to ask them if there's any pain. The reason why is because, you know, the drainage should go to the nose from the maxillary sinus. And then another thing that we're not going to do is you would take the otoscope again and you would place it right beneath the eye on her cheekbone, right? And you would turn it on and you would ask the patient to open their mouth. And if you could see a light coming through their mouth, that would mean that the patient was fine, right? But if you couldn't see that light, then you would know that within those sinuses, the maxillary sinus, you have a lot of fluid building up because you couldn't see the light coming through. So that fluid is the one that's blocking it. So that's just to check her sinuses. The next thing we're going to check is her throat, right? So we're going to take our little tongue depressor, right? So for the throat, we're just going to check the back of her throat. And the way we do that is by asking her to open her mouth. So open your mouth. And then, yeah, stick your tongue out and say, ah. Okay.
Okay, that's better.
All right. So the way she checks her, the way we check her throat is, I can't really see in there. It's dark. So we're gonna take we're gonna take our tongue depressor and you kind of put it proximal to like where the uvula is. The uvula is that little ball-like thing hanging down that you want to rise up. If it doesn't rise up, then something's wrong with her. So we want it to rise straight up. We don't want it to deviate anywhere, because if it deviates to a certain side, that may say that there's an infection to the side that it's deviating away from. It could indicate that there's cancer or tumor, or just she's sick, or there's an infection on that side. Or it could deviate in patients that suffered from a stroke. So your cranial 9 palsy is not functioning right. So let's do that again. Say, okay, so you could see a better, side of it. You want it to be dull red. You don't want it to be super red. If it's red, then you probably have an infection. One more time. Okay, so her uvula is going straight up, which we want. So she probably doesn't have an infection on both sides. And also her, it's a little dark in there. So you can use the otoscope, right? Which is what I forgot. So you can use the otoscope, turn it back on, and you just want to put it in there so you can see. So I'm not putting this too far back because she will start gagging, which it's important. You can check her gag reflexes, but in this case, we won't do that to her. Okay. Open wide here. Perfect. Okay. So she does have that dull color, and her uvula is going straight up, so that's perfect. Okay. Everything that I'm finding on her may indicate that she was sick in an earlier time, because not everything is perfect. I'm kind of just estimating. Yes, it's like not really red, it's kind of dull red, but she may have been sick before, but she's getting better. Especially you can hear it in her, like if she lost her voice or something like that. But that's how you check the throat. You also want to check if the person has tonsils, like if they didn't get it removed. You want to check the tonsils, that they're the right color, and that the uvula is still moving in that upward projection. Even though the tonsils, you want them to be the correct size and stuff like that. So I did see her tonsils. They were fine. They're going to be on the side, kind of, from the uvula. So that's the end of our... And then after, you just want to kind of ask them how they've been doing and all that stuff. So that's the end of our exam. Yay! But this is Gabriella. She decided that she wanted to be my patient. So yeah. Okay. Did I end it? Nope.